2, 1. Please start, ma'am. We are live.
So, good evening, everyone. So, it's a great pleasure to welcome you all for the today day two session. It's a clinical pathways in common cancer care. And I would like to invite Dr. Divesh Goel sir for the opening remarks. And he's a senior consultant medical oncology for Fortis Hospital, Jaipur. So, it's over to you, sir.
Yeah, thank you, Ritika, and thank you, Horizon team. And today, the day two of this clinical pathway in cancer care, the virtual webinars. And we yesterday discussed in the lung cancer as well as the GI cancer in yesterday, and we all know. So, basic aim of this virtual conferences is to update our knowledges and identify and where we can learn and we can practice in day-to-day practice what changes. So without wasting the time, the first topic is the CIPLA sponsored session, and I invite Dr. J.K. Bhagat sir, who is HOD of the Nuclear Medicine Department at Bhagwan Mahavir Cancer Hospital, Jaipur. And the topic is recombinant TSH beyond current therapy in the thyroid cancer. So over to you, Bhagat sir.
Sure, for the nice introduction and giving me opportunity to talk to you all. Though the timing has to be changed, I know must have caused a lot of problems to you, but because of my prior engagement, I had to do that.
Yes.
I'd like to share my slides. I don't know whether they are visible.
Yeah.
Are my slides visible?
Yes, sir, visible. Do in PPT mode, sir.
Yeah, I am trying to do that. Has it come in PPT mode?
Yes, fine.
So I'll be very brief. My timing is approximately 20 minutes.
15 minutes, sir.
15 minutes. Okay,
Yes.
fine. So I'll finish it within that time. And I am talking on the current role of recombinant TSH in the thyroid cancer. And the most common differentiated thyroid cancer is papillary carcinoma and follicular carcinoma, in which papillary accounts for almost 80% of the cases. And these forms are collectively known as differentiated carcinoma thyroid. Now, it is generally very slow growing and curable. Patients with less advanced diseases have 98% or higher 5-year survival rate. I have got patients who are surviving for last more than 35 years. And many patients experience the recurrences. And these recurrences take us or compel us to do the monitoring from time to time. The thyroid cancer statistics, India ranks 18th number in the world scenario. And the incidence in India is 1.5%, whereas the global incidence is about 4.1%. The death rates and the incidence in male and female differs. The incidence worldwide in the male is about 34.8% and female is 28%, whereas mortality is almost similar in both males and females, about 67 and 66%. How we typically manage the DTC patients is thyroidectomy, which is surgical removal of the thyroid gland. Then we give the thyroid hormone therapy. Before that, the radioiodine is given for the remnant ablation. And then the diagnostic and therapeutic follow-ups are done at the regular intervals. So going ahead by giving the radioiodine ablation means it is destroying the residual tumor to reduce the risk of persistent or recurrent disease and to destroy the remaining healthy thyroid tissue also to improve the sensitivity in subsequent monitoring for recurrence. The studies world over has done in DTC specific mortality 9,411 patients, in which 3 studied have shown a significant reduction in differentiated thyroid cancer. Any in differentiated thyroid cancer recurrence, 3 studied have shown a significant reduction in DTC recurrence. Loco-regional DTC recurrence, out of 1,600 cases, 4 studies, 3 studied have shown a significant reduction in loco-regional recurrence. And distance DTC recurrence, out of 2,232 patients, 2 studied have shown a significant reduction in distant DTC recurrence. This is after giving the radioiodine therapy and meta-analysis. Now, this is how we stratify the risk: low risk, intermediate risk, and high risk. Now, here the risk stratification gives us that we don't give radioiodine in low risk patient. However, in intermediate risk and high risk groups, we do institute the radioiodine therapy. Now, doses and all we will come forward. Now, here follow-up monitoring is a vital part of the DTC monitoring. And in follow-up, we follow up with the serum thyroid, thyroglobulin measurement, neck ultrasonography, and diagnostic radioactive iodine scintigraphic whole body scan. Now, these results follow monitoring and further treatments. Now, thyroid hormone withdrawal is needed to raise the thyroid stimulating hormone levels, because by doing the thyroid stimulating hormone levels, the uptake in the malignant cells is increased. Therefore, we keep the thyroid stimulating hormone levels approximately 30 micro international units per liter, which is necessary to stimulate the thyroid secretions and iodine uptake. Both are enhanced by that. Now, thyroid hormone withdrawal is typically lasts for 2 to 6 weeks. And when we reinstitute the thyroid therapy, it takes about 3 to 4 weeks to return to the basic functioning. Now, this has a limitation that there may be cerebrovascular and psychological problems. There may be cardiovascular problems. There may be renal problems. And there may be lipid problems in which increase in the lipids are known by withdrawing the thyroxine. And there are number of patients in which significant statistical values have been observed, in which the patient has depression, patient has anxiety, patient has psychomotor retardation, and physical and mental withdrawal symptoms are also there. The thyroid hormone withdrawal it has a socio-economic status problems, in which missed work time, decreased productivity, missed work days, accidents, accidental cost, and total cost of almost 1,647 euros per case, it is known. Therefore, the need of a drug which has given us a strength that we don't have to withdraw the eltroxin while we are doing the investigation and therapy and further follow-ups. And that is the recombinant stimulating TSH, which allows us to continue taking the thyroid hormone medicines and helps to avoid all the symptoms of the hypothyroidism. Now, this Thyrogen has almost 50 years. In India, this was introduced in almost somewhere in 1990s, and it has a diagnostic and follow-up complete this value. And it has the India registration was in 2006, and it is approved for remnant ablation as well as diagnostic follow-up of the scans. And this is how the patient, after having the thyroid problem, goes from doctor to doctor, and ENT surgeon and the surgical oncologist will do the surgery, and then through the endocrinologist or directly they'll come to the nuclear medicine physician for further management. The rationale for thyrogen has been very well established nowadays. The TSH improves, as we have already discussed, sensitivity and detecting the residual metabolic activity. There is no need of symptoms of hypothyroid. The patient continues to take ultrauxin and the recombinant TSS are given. I'll tell how they are given. Now, the doses are 2 injections and they are coming in one kit, 2 injections. One day and second day, the injections are given. Third day, the radioactive dose of iodine is given. Fifth day, the scan is done. Or we do, in new cases, 5th day, high dose of radioactive iodine is given. 7th or 8th day, we do the whole body scan, and then the patient is put on the ultrauxin replacement. Such cases, again, see, they are follow-up protocols and treatment pathways are there, and they are standard treatment pathways, as we have discussed: diagnosis, surgery, then initial TSH, then ablation. After that ablation, the follow-ups are done regularly. Now, this we have already discussed. There is no need to go in for this details of this slide. Now there are clinical trials and evidences of thyrogen with us. Maximum serum TSH in 2 injections goes almost up to 180 millimicrons, and that is sufficient for us. 30 or above, that is what we have to keep. And same way in the ablation, the success of withdrawal or with thyrogen injections, almost similar results are there: 100%, 86%, 86%, 96%. Same way, the success rate in short term and the long term is almost 100% in both thyrogen as well as radioiodine, as well as the thyroxine replacement. The ablation success in iodine 131 activity is also almost similar. There is no difference in these percentages. Now, thyrogen is effective in patients with high risk DTC recurrence also. In the recurrence cases also, we give the radioactive iodine after giving the thyrogen injections, and the results are similar to that of withdrawal of ultrauxin. Now, it is equally effective for remnant ablation. It has equal efficacy across the high activities. No inferior or medium long-term follow-up is there, and efficacious in patients with low, intermediate, and high-risk DTC recurrences. The low recurrence cases also we keep into the surveillance. Surveillances, and at regular interval we have to survey them. We have found that almost 5% of those patients have recurrence or nodal recurrence or lung recurrences, even in the low dose, low risk group. Same thyroid hormone therapy, euthyroid, and testing is done. Patient remains euthyroid. That is the advantage of it. Now, predictive values of repeated thyroid stimulation and testing in the case of recurrence of DTC. In the first time, it is almost 97%. Second time, it is 99.6% negative predictive value. Third time, 100, and fourth time, 100. and positive predictive value increases over the period of time, first, second, and third survey. It is safe except nausea and headache in few patients, which we have observed. No major side effects we have seen. And these are the multinational trials which also support these nausea and headache. No major problems are seen. No major adverse effects are seen. Radiation exposure is also little less in compared to the thyroxine withdrawal when we give thyrogen. So that also, that part is also taken care. Whole body radioiodine residence time after ablation in thyrogen, it is less, approximately 17 hours. And when there is withdrawal, it is almost 24 hours. So that part is also taken care.
Sir,
Now,
sorry for interrupt you. Can you conclude your session in 2-3 minutes?
yes, I am coming to the end. Now, that is what we are in clinical values. It is important in remnant ablation, diagnostic testing. It avoids hypothyroid mortality and discomfort, preserves high range of quality of life and ability to function, reduces non-target body compartment exposure, fewer side effects of radioiodine therapy, and reduces radioiodine protection worldwide. Beyond the current therapies also are there, and the Indian study also has given us a support that these patients, in which they did 37 patients, and they have found even in the lung and skeletal metastasis, or both, they have found it better. Thyrogen is a valuable drug which we should use it. Thank you. Since there is no time, I'm not going to the dedifferentiated thyroid cancer for the want of time. Thank you. Thank you so much, Divesh. Any questions? I am ready to answer.
Yeah, thank you, sir, for this talk. So definitely, we send to the patient after the diagnosis of thyroid cancer and after surgery. The patient consult to us, and we send to the nuclear medicine department for further treatment. So I think we are unaware about this thyrogen as well as for the radioiodine treatment. So I think you have enlightened in very detailed, and I think I have learned first time with this thyrogen as well as other the treatment aspect. So I learned because I have no time and we have no interest. So I think we all learned for this topic first time. I think definitely the thyrogen in comparative to the TSH withdrawal. So you have said that the better, and it also work in the ablations. So I think, sir, there is no question from my side, as you have explained each and everything in detail. Beyond my knowledge, so I think you have shared all these things. Thank you, sir.
You are
Thank
most,
you, sir.
you are most welcome. We learn from each other, and more and more such sessions are most welcome.
Yeah, thank you, sir, for my invitations and accepting. And very
welcome. I am obliged. Thank you so much.
Thank you, sir. For the next session, I will start the breast cancer session. And for this, I invite Dr. Bhavesh Poladia, and he is medical oncologist at Thangam Cancer Center, Namakkal, and he will brief on the Serena 6. So over to you, Dr. Bhavesh. So I think, Dr. Bhavesh, are you there?
Yes, I'm there. Thank you, sir. Thank you for the invite.
Yeah. So I think we will complete within 10 minutes, I think.
Yes, we'll try to finish it faster. Yeah.
Thank you.
So thank you once again at the outset. Good evening to everybody. And thank you for this opportunity. I'm Dr. Bhavesh, medical oncologist at Thangam Hospital, Namakkal. So we'll start with the breast cancer session. And this is something very interesting topic what has been given to me to present. And this is about the camizestrant in combination with CDK4/6 inhibitor. And this needs the starting of this is to be done before any anatomical progression. So this is something very unique which we have not been doing in any of the other cancers, and this has started in breast cancer. And probably I think this is the way to go for most of the subsites. So this is a phase 3 double-blind trial, which is ctDNA guided, named Serena 6 trial. So let's go through this in next 5 to 10 minutes and understand how it happened. So the main key takeaway from this trial is switching AI to camizestrant with the continuation of CDK4/6 inhibitor. And this has been guided by the emergence of ESR1 mutation, which is one of the common mutation we encounter when the patient fails or progresses on the first line of therapy. And this actually has improved the PFS. This is what we are going to see in the next few slides. And this is a first global registrational phase 3 trial, which has used ctDNA monitoring to detect any emergence in resistance in the breast cancer and try to overcome it and how to target it. So these are the findings from this trial have a potential to become a new strategy, and also it will give emphasis to other subsite to make a new new move in such direction. So basic background, we know that most of our breast cancers are HR positive, and the ESR1 gene is the one which encodes ER, and the mutation leads to activation of the estrogen receptor. Upfront cases, we see it very rarely. That's why we do not start with fulvestrant or any of the these agents, and because it is less than 5%, the ESR1 mutation. But as the patient uses hormonal therapy, CDK4/6 agents, almost half of them, 40% plus patients, will develop this ESR1 mutation, and that is where the selective SERDs are going to act, like fulvestrant and elacestrant and camizestrant. This is camizestrant especially is the next generation oral SERDs, and it has a complete ER antagonism, which is designed to inhibit and degrade the mutant as well as wild type ER. So it will completely abolish the estrogen receptor, and this is what is going to help in getting control over the disease. So basic background of the trial shows that the ESR1 mutation is detected by liquid biopsy, that is by the ctDNA, prior to the progression of AI plus CDK4/6 inhibitor. So we will see it even before the morphological or radiological progression. And this was proved before this trial has been like a thought process which has started with PADA1, that is PADA PADA1 trial, which used fulvestrant plus palbociclib in a similar setting. Again, Serena 2 used camizestrant to show that it is better than fulvestrant, and the combination of two is tested in Serena 6. So we know that this is the basic flow chart of how the patient was screened, how many were on the surveillance of ESR1 mutation, and how many were finally randomized. So approximately 300 plus patients were randomized. And this is a simple study design that patients who were ER positive, advanced breast cancer, already on AI plus CDK4/6 inhibitor, any of the three which was available, and they were at least taking it for 6 months. And now they have shown ctDNA, which is showing ESR1 mutation with no evidence of radiological disease progression. And they were randomized to either continue the same therapy or immediately change to oral SERD, camizestrant, plus continuing the same CDK4/6 inhibitor. The primary endpoint was PFS and multiple secondary endpoint, including PFS2, OS, and safety and patient-related outcomes. Various stratifications were seen, visceral, non-visceral, ESR at first detection or subsequent detection, because it is seen every 2 to 3 months, and time for how long the patient was in the first therapy, less than or more than 18 months, and also the CDK4/6 inhibitor. So this will just give an idea whether one is better than the other. So statistical design, very simple. Primary endpoint PFS, planned at least 135 PFS events should be done. So this is a baseline characteristic which is quite well balanced if we see on both the sides. And coming directly to the results, as we can see, the PFS, which is the primary endpoint, has been positive. So this is a positive trial, and almost doubling, I would say 9 months increasing to 16 months. and the number of events which were required have already been done. So this shows a PFS advantage. And if we see the forest plot chart, each and every subgroup, if the PFS, if we see each and every subgroup is getting benefited, all the points are on the favor of using camizestrant. Coming to the quality of life or patient-related outcome, again, this is positive with the use of camizestrant. And here we can see the improvement is almost 4 times, 6 months versus 23 months. Coming to the second PFS or PFS2, what we say, again, this is positive in this trial, which is one of the secondary endpoint with an HR of 0.52. And safety, coming to the safety summary, we see that hardly there is any major difference between the two, whether it is adverse event or serious adverse event, it is almost looking similar. So there is no extra safety signal which was seen. Even the adverse events, specifically looking at hematological and non-hematological side effects, were looking almost similar. Maybe little bit more neutropenia, approximately 10% more, but majority of them are grade 1 and grade 2. So this is switching of AI to camizestrant with continuation of the same CDK4/6 inhibitor, guided by the emergence of ESR1 mutation during the first line of therapy, has actually improved the PFS with the use of camizestrant. PFS is consistent across all kinds of CDK4/6 inhibitor, whether it is Palbo, Ribo, or Abima, and even the PFS2 is better. And this is the first global registrational phase 3 trial, which has shown this kind of strategy working very well. And Serena proves a potential of this specific drug and optimizes the first line patient's outcome. So I think I'll stop here and refer back to the organizers. Thank you.
Thank you, Dr. Bhavesh, for this talk. So just where we are doing the ctDNA measurement. So just we have started the AI plus Palbo or CDK4 or 6 inhibitors. So when we should do the monitoring with the ctDNA, suppose ctDNA comes after 6 months, 12 months. So when we should start, when we should do this, and
So the entry of the trial was after at least 6 months of therapy. And once we started, so that the first thing we will see is after 6 months, 6 months of the therapy. And after that, we'll keep doing it once in 2 to 3 months. So if it is earlier or later, both are actually getting benefit. But usually we expect that if it is failing early, probably this may have a bad or a poor prognostic sign. But this was overcome by the powerful usage of a newer oral SERT like camizestrant.
so definitely we know that there in the endocrine positive ER/PR positive or HR positive tumors. So definitely the more and more number of drug in our basket, and definitely with this ctDNA introduction, so the fulvestrant and next generation camizestrant and other drugs, we are finding the ESR1 mutations, and based on this we can the change the drugs according to the mutation strategy. So I think this trial is beneficial for us in future, and when the drug is available in the Indian market. I'm true.
Yes. It is not currently available.
Yeah.
But I think slowly all the companies are very welcoming for all the positive trials, and they are picking up one molecule and introducing it to DCGI and into India.
Yeah.
So I think in next 1 or 2 years, we'll see all the global molecules to be present in India.
Yeah. So thank you, Dr. Bhavesh, for this Serena trial. So thanks from my side.
Thank you so much.
For next session, I invite Dr. Rohit Rubalo, who is the medical oncologist at GBH Memorial Cancer Center, Udaipur, and deliver the talk on the Destiny Breast 9 trial. So over to you, Dr. Rohit, and we will complete within 10 minutes.
Thank you, sir.
Yeah.
Could someone please upload the slides?
Yes, sir, sharing.
Yeah.
So is it visible?
Yeah. Thank you. Good evening, everybody. The topic given to me today is to discuss the Destiny Breast 09, which is basically TDXT plus pertuzumab versus the standard THP regimen for first-line treatment of HER2 positive advanced or metastatic breast cancer. Next. So this particular combination has demonstrated almost a 44% improvement in the risk of reduction of disease progression or death when compared to the standard arm. And the safety of this combination was consistent with known profiles of individual treatments. So the combination of pertuzumab with Enhertu has demonstrated a statistically significant, clinically meaningful PFS benefits. So let's just go through the entire study to understand what was done during this particular study. Next. So basically, what we know today is the Cleopatra study is currently the standard of care. The phase 3 data showed that it had a progression-free survival of about 18.5 months. So one in three, but one problem with this particular study was 1 in 3 patients do not receive subsequent treatment after the first line. The standard second line today is obviously based on the Destiny Breast 03, which showed a significant benefit in progression-free survival of 28 months compared to 6.8 months when compared to TDM1. And in the third line, if a patient has not been exposed to Enhertu, then they have options of going for TDXD in the third line also. Otherwise, there are other options like CAP-LAB, tucatinib-based combinations, which we use in the third line. Next. So what is the rationale of combining pertuzumab with trastuzumab deruxtecan? So what basically pertuzumab does is it prevents the heterodimerization of the HER2 receptor with the HER3 receptor. And trastuzumab prevents the homodimerization of the HER2 receptor. And also because there is a chemotherapy molecule loaded into Enhertu, this chemotherapy molecule then gets internalized, the TDXD molecule gets internalized, and then it releases the cytotoxic payload, which then again causes apoptotic cell death, and that again tends to cause bystander effect. So because of this synergism of both these molecules, it was decided that combining these two molecules would result in a significant benefit in the in patient survival. Next. So the eligibility criteria that we see here is basically HER2 positive advanced or metastatic breast cancer with asymptomatic or inactive brain mets were allowed with a DFI of more than 6 months from last chemotherapy or HER2 positive targeted therapy. And one prior line of endocrine therapy for MBC was permitted, and no other prior systemic therapy were randomized to TDXD plus placebo, TDXD plus pertuzumab, and THP, which is the standard of care based on the Cleopatra study, with the primary endpoint being PFS and the secondary endpoint being overall survival. Next. So in the interim analysis of PFS, which was the primary endpoint planned after approximately 399 events across 3 arms, they found that there was a superiority was already met for TDXD plus P versus THP. TDXD plus placebo remains blinded until final PFS analysis per protocol. And that's going to be an interesting result to compare, because we would want to know whether pertuzumab actually adds something to this or whether TDXD alone is sufficient. The first interim OS analysis, 126 events had occurred, which is about 16% of the total, and final OS analysis will be conducted as per protocol. So we don't have that data. Next. Next. So what we see here is they were randomized 1:1:1. About 1,157 patients were taken. In the TDXD plus pertuzumab arm, there were 383 patients, and about in this particular arm, 21.3% had a progressive disease and 20% had adverse events. So in the TDXD plus P arm, 8.7% of the patients shift to trastuzumab after discontinuation of TDXD for reasons other than progressive disease. Concurrent endocrine therapy use was seen in 13.5% of this experimental arm versus 38.3% amongst patients with hormone-positive disease. The median duration of follow-up was about 30 months. Next. So these are the various criteria. Most of the patients were ECOG1, with few patients being, most of the patients were ECOG0, with few patients being ECOG1. And about 83% of the patients actually had IHC positive, and about 16% were IHC less than 3 but had ISH positive. And 54% had hormone positive disease, and about 52% of the patients were de novo at diagnosis. About only 6.5% patients had brain metastasis, and about 80% of the patients had visceral metastasis. Next. So when you look at the prior therapies, they were again equally matched between both arms, with 40% of the patients having received some sort of neoadjuvant therapy and about 20% of the patients having received endocrine therapy. Next. So if you see the PFS, there is a significant separation on the curve that starts from 6 months, where it is 93 versus 87%, and then keeps increasing. And if you look at the separation of the curves at 2 years, it is 70.1% versus 52.1%. So there's a significant benefit about 18% with a good hazard ratio of 0.56 with significant p-value. The median being 40.7 versus 26.9. So there's a significant benefit of about 14 months. Next. So even in the investigator assessment, the PFS hazard ratio was 0.49, which is quite significant, and the difference is even greater with a 20-month difference between the two. Next. So the benefit was seen in all subgroups, whether they were hormonally positive, negative, de novo, recurrent, age. Only thing in age more than 65, probably it crosses unity. But other than that, most of the subgroups, Asian as well as Western population, had benefit with this combination. Next. So if you look at the confirmed overall response rates, they are 85.1% versus 78.6% in both the arms. And the duration of response was 40 months versus 26 months, with persistent response present at 24 months of 73 versus 54.9. Next. So the overall survival is still not mature and probably will need a much more longer time to see where the OS is going to actually, land at, because the median OS has not yet been reached for both the arms. So probably this is something that we will only see after about 5 years, where, you might see the curve separating. Next. So even the PFS2 was significantly better. It has not been reached in case of TDXD plus P, whereas it was 36.5 months with the THP arm. So clinically meaningful improvement was seen with PFS2 also in this particular study. Next. So these were the known adverse events. The total treatment duration for TDXD plus P was 21.7 months. For TDXD was 20 months, and for THP was 16 months. The treatment duration for taxanes ranged between 0.7 to 37 months, and paclitaxel between 0.2 to 30 months. Docetaxel, a median of 8 cycles were received, and paclitaxel, a median of 6 cycles were received. Next. So the side effects are based on what drugs were given. So one can see that nausea and diarrhea were significantly more in the experimental arm because of the drugs, as well as, peripheral sensory neuropathy was more common in the THP arm because of the use of taxanes. So no unusual side effects were noticed in this particular study. Next. So ILD is a significant problem that we face, and in the TDXP plus P, you saw about 7% of patients developing, grade 2 ILD, and they also about 8% of the patients did have grade 2 left ventricular dysfunction, which is also seen in trastuzumab THP combination, but the numbers are still higher with the TDXD plus P combination. The worrying side effect being pneumonitis. Next. So as we discussed before, this particular combination did show a statistically significant benefit in PFS versus the standard THP combination, and may represent a new first-line therapy. But the data is too immature right now for us to make any, great calls in our change of management. But definitely it is something to think over, and we really do not know what is going to happen in future, because what happens if you give THP in the first line and TDXD in the second line? So we need to prove that that combination is not inferior, because using TDXD in the first line is something that we would be worried, because pneumonitis issues are quite significant, and THP has been a great friend to us for the last decade or so, and it's you see about 33% of the patients surviving up to 8 years, and that is before TDXD came in. So we need to know how to sequence this drug. Is going to create some amount of complications in sequencing, but then it's definitely great to know that this is one option that probably is going to come into the first line. And I'm also still waiting for just the TDXD arm. Does pertuzumab really add much to this combination or not? So thank you, sir.
For this, so just in my view, we are just saying that TDX plus PER2 can be given in the first line. The trial is showing. So I think for what next? If the disease have progressed or if this combination is not tolerating, so what next after the TDX plus PER2?
So then we have to go for Cap-Lapolis or tucatinib-based combinations with chemotherapy. So there is no other option other than that remaining. But I still want to see what TDXD alone does.
Okay.
And also we need to figure out whether we can use pertuzumab now in the later lines. I think that's one more question we need to test.
So I think in my view, and first setting, so definitely THP is can use, and we can fit the TDX in the second line if the disease have progressed. So I think
Yeah, even I would prefer that, sir, because TDXD again tolerance is not that great. ILD rates are much higher. That would, but we need to look at the OS data, sir. At the end, that's what will decide our final.
so your experience with this TDX in the MBC settings with HER2 positive.
It is a good drug, sir. But obviously pneumonitis does cause problems. You need to be very, very aggressive with a little amount of cough. You need to check. Works quite well, but I still feel it works better in earlier lines than later lines.
Yeah. Thank you, Rohit, for this talk. Very well. Yeah.
Thank
Thank you for my invitation. So the next session is the Zydus sponsored session. And so for this, I invite Dr. Ankur Punia, who is the assistant professor at Mahatma Gandhi University, and the topic is the systemic control of brain mets in the HER2 positive metastatic breast cancer. What's new for us? So over to you, Dr. Ankur.
Yeah, good evening. Thank you for inviting me for this session. So I'll share my slides.
So I think earlier 5 or 10 minutes before.
So are you able to see my slides?
Yeah, yes.
Okay. So the topic now given to me is, as we are in the line of discussing HER2 targeted therapies. So basically now we have multiple therapies with us. So how do we strategically sequence these therapies with the availability of one more drug to us, which is tucatinib, I think, which is well worth awaited, quite useful for many patients. So we have now a big armamentarium of HER2 targeted therapies. We have monoclonal antibodies. We have trastuzumab, pertuzumab out of these. Now we got the HER2 targeted ADCs. We had TDM1. Now we got TDXD. There are multiple TKIs also. We only had access to lapatinib till now. Naratinib is available through patient assistance program. Now we also got the tucatinib. So now we have multiple options for these patients, which can be used to prolong the life of this HER2-driven breast cancer. So how will we optimize, sequence these drugs, which drug to give first, second, third, as was being already discussed in the current era. So first line standard of, as was discussed, first line standard is the THP, which is pertuzumab, trastuzumab, and chemotherapy based on the Cleopatra trial, in which the patients were randomized between whether to give pertuzumab or the trastuzumab alone. So basically, this is now the standard of care, showed a good improvement in overall survival, a 17-month delta, median OS of 57.1 months. Similarly, a 6 months improvement in PFS, reaching around 18 months. Based on this has been the standard of care for a long period of time. And with that destiny, this might be, challenged in the future, and we get the long-term outcome of the study. But still, it's the standard landmark trial which changed the paradigm of the HER2 positive breast cancer patients. So now coming to second line patients who has progressed on this first line therapy, we had the Amelia study earlier, which showed that TDM1 works better than lapatinib capecitabine in the second line setting. So there were very few patients with brain mets were included in this trial, but still it improved the PFS as well as the overall survival by not that big of a margin, but still a good enough difference for long term. So it became the standard of care. Then eventually came this Destiny Breast 003 study, in which they randomized patients between trastuzumab deruxtecan versus TDM1 in the second line setting post first line treatment. And we clearly see a remarkable difference in, PFS was, there's a daylight difference between the PFS in both the arms, 28.8 versus 6.8. Similarly, almost 10-month improvement in the overall survival as well. So basically making it the standard second line treatment in the second line setting post first line trastuzumab pertuzumab. What do we do for the patients who develop brain mets in the second line? Brain metastases are quite common for HER2 positive metastatic breast cancer. In HER2 per se, almost around 50% of patients will develop brain mets eventually in this class of disease. And most of the earlier trials have excluded, and bigger phase 3 trials have excluded patients who had a baseline CNS disease or treated or untreated. So we know that CNS mets are one of the most worst disease to have because we have limited options to target them. So ideally, we do a brain MRI with or without contrast to confirm them. It's now sort of a standard part of staging. So nowadays, it's even recommended for HER2 positive breast cancer that we should do a baseline MRI as well to confirm the status of brain metastasis like we do for lung cancer. Biopsy, if it is the only site of recurrence, is a must. Neurological consultation can be taken if patient is a candidate for if surgery. If the patient has limited disease, we can give systemic steroids for edema. Then there comes multidisciplinary treatment, whether to give radiation or start go for surgery or to give systemic therapy. So here comes the role of this drug per se based on this HER2 CLIMB study, which for patients for metastatic HER2 positive breast cancer who has progressed on first line Cleopatra regime, then have taken TDM1, and patient who had a brain mets were allowed in this study, though they were they were treated stable mets or untreated who didn't require any immediate active treatment. So sort of asymptomatic mets or treated mets were allowed. So in this, what they did, they randomized between tucatinib, trastuzumab with capecitabine versus just trastuzumab in capecitabine. The primary endpoint was PFS. As I told you, brain met patients were there, so almost 50% of patients in the study had brain metastasis. 174 had active brain mets and 117 had stable brain mets. If you look at the response rates in CNS response rates, it was more than doubled. It was 47% versus 20% with the addition of tucatinib. Look at the overall survival. Its overall survival also significantly improved. Median was 21.6 versus 12.5 months with a delta of almost 9 months. But we look at 2 years, almost twice the number of patients were alive who had brain mets, which is a big thing because eventually patient to brain mets don't do that much well. But at 2 years, almost 50% of the patients were alive in the tucatinib arm. So we look at particularly the CNS, progression-free survival. You can see it was markedly again improved. It was 9.5 versus 4.1 months. And at 1 year, almost all the patients in the control arm had progressed, whereas 35% patients were still on the drug at 1 year. Same for the overall survival for patient who had, active brain mets. OS was almost doubled. You can see at 1 year, almost 70% patients were still alive who had a brain metastasis, which is a very good result for these patients. So similarly for patient who had a brain mets but were stable brain mets, more or less the same thing. PFS was again remarkably improved. It was 14 versus 5.6 months. Again at 1 year, almost half the patients who had stable brain mets were progression free, whereas almost none in the control arm. Similarly, overall survival was slightly improved, not significant, but almost 10% more patients were alive at 1 year who had a stable brain metastasis. We had evidence with TDXT in brain metastasis of multiple pooled analysis and all. It shows response in brain as well. Destiny Breast 2 has been reported, which show that it works in patient who had brain metastasis as well. So it is one of the other option which can be used for these patients. So now we have multiple options. So how do we might sequence? So this is sort of preferred, which is shown in the ESMO guidelines as well for those patients who have active brain metastasis, or for patients who have asymptomatic brain metastasis. Tucatinib, trastuzumab, capecitabine might be one of the option. Or for patients who have a systemic progression along with CNS disease, then either this combination or TDXT is a well good enough option. Yes, for patients who cannot take these drugs, lapatinib is the other options. And we can down the line use the drugs which we have not used in the earlier setting. So one of the multiple options which I already discussed, other regimens which have been tried are with now tucatinib, Just try with TDM1, neratinib, and pyrotinib. Also have study with capecitabine, but we don't have these drugs available to us. So this is one of the other drug, Hertucline-02, other trial in which they compared tucatinib plus TDM1 versus just TDM1 in patient who had prior treatment with trastuzumab or previous treatment with lapatinib or neratinib in the earlier line setting was allowed. Brain mets patients were allowed in this. Primary endpoint was PFS. And PFS again was improved if we combined tucatinib. It was 7.8 months versus 5.7 months with the hazard ratio of 0.64. Response rates were also slightly improved. It was 42 versus 36%. More patient had a partial response. Overall survival was still not reached in the combination arm, where it was 38 months in the placebo arm. So if you go beyond that, we have used all the drugs what to use in third line and beyond for HER2 positive breast cancer. We have to see it on a case by case what kind of treatment the patient has already received. So this is one of the study which again, which I've already told you in the third line setting, which was Hertucline study, which more or less showed the same thing, that the combination had a response rate of 40 months, PFS 7.6 months, and overall survival of 24 months in the third line setting post patient has progressed on THP and TDM1. So again, this drug has showed good results in the even in the third line setting of HER2 positive breast cancer. So again, TDXD is also an option in third line for patients even after TDM1 based on this Destiny breast which was initially presented. It remarkably improved the PFS 17.8 versus 6.9 months. Again, OS was also very much improved, 40 versus almost 26 months. Other options which we have are like neratinib, again oral TKI. It has shown that versus in the NALA trial along with capecitabine versus LAPCAP, it showed improvement in the PFS, but not statistically significant OS improvement. Similarly, other pyrotinib is another TKI which has been shown to work better as compared to placebo, but we don't have access to this drug. Another HER2 antibody, margetuximab, it's more or less similar but slightly different, monoclonal, that antibody structure is there in a SOPHIA study for post progression on 2 lines of therapy. It showed improvement in PFS and OS, but all of these drugs are not available to us, and the magnitude of benefit by adding this drug is not that much as compared to what has been seen with tucatinib. So fourth line or beyond, if we go, we have now multiple options. We look at the NCCN guidelines. So basically what we use is what has been not used in the earlier line setting. Most likely we use trastuzumab with the chemotherapy which has not been used earlier or has been used a long time back, or some of the another TKI along with chemotherapy can be used. So basically the refined approach is this newest guidelines of ESMO metastatic breast cancer. So first line, if we don't use chemotherapy, we use that combination of trastuzumab, pertuzumab along with endocrine therapy. If we have to use chemotherapy, then the THP regime is the standard, followed by we continue trastu, pertu plus endotherapy when it's indicated. And for hormone negative, more or less the same thing is used second line. Either if we can use TDXD or TDM1, TDXD is preferred all because of the better results. For active brain mets, tucatinib, trastuzumab and capecitabine is one of the combination which can be used. In third line setting, more or less the same drugs which have not been used in the second line can be used in the third line. And fourth line, as I already told you, we sequence whatever drugs which we have and which have not been used in the earlier line setting, those can be sequenced. So we have now quite a good number of drugs available to us in this setting, and this is one of the subgroup of breast cancer patients which are now living for a good number of very long period of time, almost matching how much I say slowly approaching how much a hormone positive breast cancer patient lives. We are approaching that with now HER2 positive metastatic breast cancer. So as more drugs are getting available to us, we are getting more and more. We have now biosimilars of all these drugs available to us which were not available, and it has grown our armamentarium because more number of patients will be able to afford these drugs and might be able to take the best benefit of what is we are seeing in the trials, we will see in the real world setting. Thank you. You are mute, Dr. Divesh.
So thank you so much, Dr. Ankar Punia sir, for
Yeah.
the session. So moving at Dr. Divesh.
Yeah, So thank you, Dr. Ankur. So just want to know, can we give this drug tucatinib without the trastuzumab, tuca plus capecitabine combination? Can we give?
I think it can be used. I don't see any point it won't be used. So it might just, there is some evidence that, combining a TKI with trastuzumab shows slightly better response. But I think it can be used irrespective of trastuzumab.
Okay, so which drug, TDX versus tuca plus trastu plus capecitabine, which regimes you prefer? Even in
It
active
depends
brain.
on what patient can afford.
Thank you. Thank you, Ankur. Yeah, we stay here. So thank you, Ankur, for this session, and thank you for Zydus for sponsoring this session. And for the next talk, I invite Dr. Hemant Malhotra, sir, and he is professor and director in the Sri Ram Oncology Institute at Mahatma Gandhi Medical College and University. And sir, my pleasure to invite you for this Novartis sponsored session. And over to you, sir. Sir, you are not audible, sir. Yeah, I think you are mute.
Okay, am I audible now?
Yes, sir, yes, sir, yes, sir.
Wonderful. So thank you, Divesh. Thank you very much. Can you identify my panelists for me, please? Who are my panelists?
Sir, Dr. Jitendra Pelajani, Dr.
Anji.
Ankur Punia,
Anji.
Dr. Ankit Agrawal, and Dr. Ajay.
Right. Okay, so everybody is joined. I can see Jitendra, I can see Ankur. And what about Ankit and Ajay? Can you please put your video on so that we can see you?
Good evening, sir.
Very good evening, Ajay, and very good evening, Ankit.
Sir, good evening.
So all set, should we start?
Yes, sir, yes, sir.
So can I share my slides, Divesh?
Yashika, please share sir slides. Sir, you can share. You can share also.
Okay, so you permitted me to share?
Yes, sir.
Okay, can you see my slides?
Yes, sir.
Okay, wonderful. So once again, good evening to everybody, all the listeners, my good friend Divesh, and all the panelists. It's a pleasure and honor to be you, and sincere thanks to Divesh for this opportunity. And we are going to, in this panel discussion, review the first line treatment of HER2 positive, hormone receptor positive, HER2 negative advanced breast cancer. So we are not going to talk about adjuvant setting and early breast cancer. We are not going to talk about HER2. Ankur has already done that. We are going to talk about advanced breast cancer, metastatic breast cancer, which is hormone receptor positive and HER2 negative. So this session is supported and sponsored by Novartis, and these slides have been provided by Novartis. So that is the disclaimer which I have to make to you. So to start the ball rolling, there are certain complexities when a patient of advanced breast cancer who is who is hormone receptor positive comes to you, de novo, newly diagnosed patient, or you diagnose that patient. And some of the key goals or considerations for the clinician when a patient like this comes are, of course, the patient-related treatment goals. You want your patients to have the maximum survival with a maintained quality of life. And your treatment decision will also factor in presence of aggressive features, in the sense that does the patient have visceral metastasis? Are there evidences of clinically aggressive disease? If any one of these things are present, then there is a thought process that maybe chemotherapy might be a better option. We'll discuss that in the subsequent slides. And then but in the advanced setting, has the patient, what earlier treatment the patient has received? Is it a treatment naive patient? Is it a patient who's received adjuvant endocrine treatment in the form of aromatase inhibitors and then relapsed? Or it is a de novo fresh patient who has come to you? So this is a snapshot of the current ESMO guidelines. Patients with hormone receptor positive, HER2 negative breast cancer. If there is eminent organ failure, then the choice of treatment is chemotherapy. Otherwise, for all stable, settled patients, which is, I think, the majority, the choice of treatment is endocrine treatment with the CDK4/6 inhibitors. And then second line treatments are, of course, depending upon whether the patient has a BRCA2 mutation or not, whether the patient has a PIK3 mutation or not, and if the patient has a target, you give targeted treatment. Otherwise, there are several second line options of treatment. And in the third line or maybe in the fourth line, chemotherapy is reserved for treatment. So let's talk about a reference case today. So all my panelists, please listen to this carefully. Jitendra, Ankur, Ankit, and Ajay. Our patient is a 64-year-old postmenopausal lady. Initial diagnosis of strongly estrogen receptor positive, progesterone receptor positive, and HER2 IHC 0 staining, early breast cancer, had the usual standard treatment, breast conserving surgery, followed by adjuvant radiotherapy and adjuvant aromatase inhibitor in the form of letrozole. So she completed 5 years of letrozole, and 2 years after completing the letrozole, she had disease recurrence. And so this is the summary of the patient here in the right side gray box. And now let me come to my panel. Given all of us would agree, or anybody would disagree, then in a patient like this, who is stable, who has multiple bone metastases, a few lung metastases, liver is clear, performance status is 0 to 1. Everybody would agree that the choice of treatment, what would be the choice of treatment? Let me start with Jitendra. Jitendra, what would you feel should be given to this patient?
Well, after biopsy, hormone therapy along with CDK4 inhibitor.
Sorry, come again?
After biopsy, hormone therapy with CDK4 inhibitor.
Correct. So you would like to do a repeat biopsy and look at hormone receptor positivity again. Anybody, Ankit, do you agree with that?
Yes, I think CDK4/6 inhibitor with hormone after biopsy.
So this she's two years post adjuvant letrozole with the CDK4/6 inhibitor. What would be your companion endocrine therapy?
So she has progressed. She has relapsed after 1 year of completing adjuvant. So she's
2 years.
Still,
2 years. 2 years.
She's still endocrine sensitive. She'll be labeled as endocrine sensitive. So what I will be giving is, again, we can re-challenge with letrozole. She can also be given fulvestrant. Both are good options.
So Ankur, do you agree? What would be your choice of the endocrine partner to a CDK4/6 inhibitor?
So see here, if possible, I would like to do 2 more tests. I will try to look for PIK3CA as well, along with ESR1. Though patient has progressed 2 years, she comes in the definition of endocrine sensitive, but still around 20% of patients might develop post-endocrine therapy ESR1 mutation. And so it would be better if feasible. Otherwise, I will be happy if patient has been, as per guidelines, is sensitive, I can challenge with letrozole. But if I will feel that if possible, I would like to do a ESR1 PIK3 now, because we had some evidence regarding adding a PIK3 inhibitor as well.
So adding a PIK3 inhibitor to endocrine therapy and CDK4/6, is that the standard of care?
So now the drug has been, I think, approved, ivanolizumab, and we might get soon in India as well, that PIK3 inhibitor.
And if suppose you do a PIK3 at this point of time, when the patient has the first metastasis and the PIK3 is mutated, then would you use a PIK3 inhibitor upfront here at this point of time?
When that we get that drug, sir, that ivanolizumab. Otherwise, no.
Okay, so now let me ask the most difficult question to Ajay. Ajay, you have a choice of 3 approved CDK4/6 inhibitors in this setting. What out of the 3 PIK3CA inhibitors would you choose? And please don't be influenced by the fact that this is a Novartis supported panel. What would you genuinely do if a patient like this comes to you tomorrow or coming Monday? And I'll ask this question to the other three panelists also. So be ready with your answers. First, Dr. Ajay.
So, sir, I will discuss with patient what is the financial status of patient, if patient is affordable or not, and the second thing I will discuss the adverse effect of all these three drugs. If patient can afford, and then I will discuss the side effect profile of all these drugs. If patient don't want diarrhea, then I would avoid abemaciclib. Otherwise, palbociclib or ribociclib.
Okay. Anybody? Jitendra, you want to add anything to what Ajay has said?
So it might look something biased from my side, but I just want to comment on what Ankur was telling, that PIK3 and ESR is needed, because if ESR is mutated, I would try to, if ESR is mutated, so there are three scenarios. If ESR is mutated in PIK3,
I don't want to talk about that scenario. Just answer the
okay.
question which is
So
on your
coming to
screen.
this, the ribociclib is the preferred choice if patient can afford. And the point is because it has maximum data of overall survival. 3 trials, phase 3, which with good toxicity profile. Palbociclib, although various if but was not able to give any overall survival advantage. Abema is a difficult drug to give at 64 because of the diarrhea, as Dr. Ajay sir has told. So probably ribociclib is safest if patient can afford.
Okay. And Ankit, what is your opinion and what would be your choice?
Sir, I think the first thing that decides my option of the 3 CDK4/6 is definitely the affordability, and the toxicity profile is also one major reason why what CDK4/6 should be given. Considering GI toxicity, if patient already has history of GI toxicity or a venous thromboembolism history, probably abemaciclib will not be the preferred option. If a patient has cardiac history, probably I will not be very keen in using ribociclib. So definitely the side effect profile will be one major reason why which one to choose.
So Ankar, any addition from your side? Which of the 3 CDK4/6 would you choose?
So, sir, as if I want to use, I will prefer to use abemaciclib as a first, preferred therapy if patient can take it. Side effects are what I feel is quite manageable. We have learned it and we have, understood it. So I'm not afraid of those. Yes, I will explain to the patient if patient is willing to take. My first preference would be abemaciclib.
And in what situation would you prefer to use palbociclib?
For patient who cannot afford these drugs, sir.
Correct. So I think all of you brought out very important points. The first thing which we should consider in deciding which CDK4/6 to use is the cost. All of us are aware that palbociclib, the generic version, is available. It's also available in the essential drug list of the government. So that would be a choice if the patient is that she wants treatment under the Chiranjeevi program or the MA program. And then amongst the other two, the most important factor in deciding the choice would be the side effect profile and the comorbidities which the patient has, right? So all of us are aware of this. These are the 3, head-to-head comparative trials. The Mona Lisa 2 trial, which approved ribociclib in this setting, the Palomar 2 trial, which approved palbociclib with letrozole in this setting, and the Monarch 3, the abemaciclib trial, which approved abemaciclib in this setting. And if you further split this into whether the patient had endocrine therapy, whether the relapse was early versus late, there is data for all the 3 agents, possibly data for abemaciclib in endocrine resistant patients is less as compared to the other 2 agents. Of course, across cross-trial comparisons are to be avoided. But if you put all these 3 pivotal studies side to side, then this is what you can presume and conclude. And again, you're aware of these 3 studies and the hazard ratios in favor of CDK4/6 plus endocrine therapy versus endocrine therapy alone. And you can see that the hazard ratios are, almost similar. They're so similar that sometimes you wonder whether they all sat down together and manufactured these hazard ratios like 0.5, 0.5, 0.5. And also the progression-free survivals, they're also, very, very similar. So if you choose a combination of a CDK4/6, whatever the CDK4/6 you choose with an endocrine partner, then you can expect your patient to have a progression-free survival for approximately 2 years. And all the 3 studies are strongly statistically significant. Then with regards to the overall survival, you can see the middle row, which is the palbociclib. This is not statistically significant, and significantly statistically significant is the ribociclib hazard ratio, and just on the borderline, missing it by just a few points is the abemaciclib hazard ratio, just missing the statistical significance. So how much importance do you give to this slide? Again, cross trials, some comparisons are to be frowned upon, but let me start with Jitendra again. How much importance do you give to the overall survival and the 3 agents, looking at this hazard ratio and the p-value?
So being a medical oncologist, we do understand that all the patient will progress. So when the patient will progress and he asks or she asks that why I was not given a drug which had a significant overall survival advantage. So I should always give them the data that this is the drug which is persistently giving OS. That's why I told probably I looked biased, but I'm keeping myself safe. That's what it is.
Okay, so I think Ankur, you kind of categorically did not sit on the fence and categorically opted that you would use abemaciclib. Does this impact you? Like, does this overall survival or the lack of statistical significance in overall survival, does this affect you, upset you, impact on your choice?
So we look at it, yes, it just missed by that overall significance. But you look at that OS difference, the PFS difference, and it's more or less what is seen with the Mona Lisa study. So I'm pretty much convinced looking at it that there is not much of a difference between either of those. So either of those is a good option for me. Just because it's missed a p-value difference, it will not deter me to prefer this drug over the other.
So I think I would also like to pull in our program director this time. I don't want him to fall asleep while we are doing our panel discussion. Divesh, looking at this overall, the overall survival here in this column is pretty much sitting on top of each other, as particularly for ribociclib and abemaciclib, but statistical significance is only for ribociclib. So will this impact your choice, and what would your choice be?
I think I agree with Dr. Ankur. So I still not believe on this p-value, but for abemaciclib, there is overall survival is better. So I think if patient profile is suitable, affording, and GI side effects are not, so my preference is first is abemaciclib. And if there is slightly differ from GI side effects are more, so we can shift on this ribociclib. So first abemaciclib followed by the ribociclib.
Okay, Ajay, any comments from your side? Will you be hugely impressed or not impressed by the overall survival with ribo and the lack of overall survival statistically significant with abema? Ajay?
Sir, as PFS is same, but in Palmares 2 trial, it was found that ribociclib have better OS in comparison to these 2 drugs.
Okay, so I think my panel is split 50-50, and that is how it should be, if I were to make a comment, then I would, choose between the 2 agents. Palbociclib is possibly not as good as the other two agents. And if you have to choose between the other two agents, then the comorbidities which the patient has and the side effect profile which the patient would accept more easily, or the patient's lifestyle would accept more easily. I mean, you would probably decide between these two agents, keeping those factors in mind. So if we consider it, I think we've already discussed it. I think this is one more question. Maybe Ankit, you can try and answer this. Would you consider PFS will always translate into PFS advantage will always translate into an overall survival advantage? And is the PFS a surrogate for the overall survival?
Sir, I think usually what we have been reading is PFS has always been a good surrogate marker for overall survival. But when we talk about CDK4/6 inhibitors, all the three drugs have almost a similar PFS of around 2 to 2.5 years, and yet only Ribo has provided a significant OS benefit. I think I will agree with my panelists that currently I think we are all in a similar platform. Probably the side effect profile should decide what CDK4/6 to use, especially when it comes to Ribo plus Abima.
Yeah, and if I were to add something, if you have a disease like a hormone receptor positive metastatic breast cancer, it's a slowly growing disease, and you have several lines of treatment, several lines of endocrine treatment, and several lines of chemotherapy treatment. And when you are, then, in addition to PFS1, PFS2, PFS3, all those become important. And then, the overall survival is kind of not that clear. So in slowly growing diseases, many times you may see a PFS not directly proportionate to the overall survival. So I think let me ask this to Ankur. Ankur, would you view the CDK4/6 for both endocrine sensitive versus endocrine resistant population? And like to highlight for you that in the abemaciclib trial, the patients who had early relapse, like within first 12 months, the patient subgroup in which endocrine resistance is likely were not included. Would that impact on your choice of treatment?
Sir, I don't think it will impact the change because it has been seen now in subgroup analysis of all the trials that CDK4/6 inhibitor shows results irrespective of whether the patient was ET sensitive or ET resistant. Yes, patients who are ET resistant will do slightly worse, but CDK4/6, these patients will benefit from CDK4/6 irrespective of ET sensitivity.
You want to add anything, Jitendra?
So I would like to agree because Abema has a single agent data also without even hormone therapy in penta or quarter refractory endocrine sensitive patients. So we do have data that these drugs work independently of ET partner, and they give us a good response rate in PFS.
Any other comments from anybody?
Sir, I think I'll agree with everyone. Abema has there were no resistant patients in the Monarch 3 trial, but overall meta-analysis has suggested that Abema probably is slightly better than Ribo and Palbo when it comes to primary endocrine resistance especially. So it should work in secondary endocrine resistance as well.
So this is the snapshot just to highlight that the inclusion criteria in Mona Lisa 2 and Monarch 3 were a little different. And I think we've already discussed this, that the patient population in Mona Lisa 3 with a treatment-free interval more than 12 years, it had to be there for the inclusion. So we've already discussed this, so we kind of move on. And again, this is a little bit of the same, like the overall survival benefit with Ribo is more pronounced than Abema if you look at a similar patient population, particularly in patients who had treatment-free interval of more than 12 months. But just shade difference, and again, a cross-trial comparison, which is a little unfair. And this is the hazard ratio of overall survival in patients who have endocrine resistance. Palbociclib, maybe not surprisingly, did not do well at all. Hazard ratio was 1.1. However, abemaciclib and ribociclib, they all had significant shift to the left and significant hazard ratios. Maybe a shade better for ribo as compared to abema. Then again, cross-trial comparisons, and I don't read too much in this. So would you agree, Jitendra, that palbo stands apart and between abema and ribo, if you look at this hazard ratio for overall survival, there is you wouldn't give it you wouldn't lose sleep on that account, right?
Yes, sir.
Okay. Any other comments from anybody? Ajay, would you like to agree or disagree?
No, sir, I am agree.
Okay, so let's move on.
Sir,
yeah,
just want
please.
to ask. Sir,
Ah.
we all are using, sir, palbociclib in the more number compared to the ribociclib as well as abemaciclib. And we are seeing that patients are surviving more than 3 years, 4 years, 5 years. So how can, sir, the data is definitely better for the abema and ribo. So where we can stand this palbo in this era, sir, Abhi, where the generic is available.
So if you ask me off the record, and I don't think you're going to ask me off the record on this panel discussion, I'll tell you my personal take. I think it is just a matter of the inclusion criteria and the primary and the secondary endpoints in the different trials.
Yes, sir.
I mean, it would be really odd if you have exactly the same PFS and you have such a big difference in overall survival. And there are several studies of palbo in the real life setting where they have, shown overall survival benefit also. So one thing which I'm absolutely clear in my mind is that it is much better to give palbociclib to our patient of hormone receptor positive disease than not to give a CDK4/6 inhibitors. And I would, extend my neck a little bit more. I mean, I do the same for in the adjuvant setting also. That we are not discussing today. But if I have a patient who has 12 lymph node positivity, then in the adjuvant setting, I would have no hesitation and the patient cannot afford abema or ribo, I would have no hesitation in offering that patient palbo. So I don't know whether you agree with me or not, but it is that, maybe the sixth sense which you develop after many, many years in practice.
I think
Anybody
that
wants to
most-
vehemently disagree with me?
No, sir. Most of us, I think, are practicing same in adjuvant setting.
Yeah. Yeah, but of course, data is data, and guidelines are guidelines. But for the individual patient, you always have to think out of the box and innovate. That is where the art of medicine and the art of oncology comes in, no? And that is, if you combine that with science, then it is in the interest of the patient. Agreed?
Yes, sir. Yes, sir. Agreed.
So Divesh, tell me when to stop, okay?
Okay, sir. Fine, sir. I can continue, sir.
Okay, so now the next question to the panel, and I think let me direct this to Ankur to start with. So how do you balance efficacy, safety, and quality of life data? And how much of impact does this have in your clinical decision making? Clinical decision making meaning the choice of the CDK4/6 inhibitor.
So yes, sir. First of all, it actually matters based on comorbidities, which was already discussed. What kind of comorbidities patient has, and what kind of side effects which we feel the patient might have in the future might affect the quality of life, because we know these patients are going to do for a good period of time. They are going to do well, so they would like to do well with the minimum side effect as possible. So yes, for this subgroup, we have to look at safety is a paramount for this patient. We don't know doubt about it. Efficacy definitely matters, whatever therapy we give. So all of these things matters. It matters at a different stage, and you cannot quantify which matters more. Each matters at their particular space of their in the triad of all these things.
So Jitendra, you want to add something? How important is quality of life of the patient when you are anticipating that the patient will have to take the pill, the treatment for 2 years, 3 years, sometimes 4 years?
The quality of life is definitely important, but efficacy and safety is also a part. But patient usually think of quality of life. That is what we have seen.
Yeah, so I mean, it's actually very easy for us to, kind of sit on our high chair and decide that, okay, this is what the patient should take. But, as you get older and as you get more and more gray hair, and maybe Divesh will agree with me, that you need to involve the patient in the decision making.
Yes.
Suppose
So if
one
yeah.
point come in my mind. Suppose the
yeah.
patient have taken the treatment of breast cancer at the age of 65 years and completed the all 5 years treatment, and then relapse come at the age of 82 years. So, and that time the patient is not suitable due to some cardiac comorbidities and some things else. So in 1 or 2 patients, I have just tried fulvestrant single agent along with this exemestane. So there is the patient is not fit for the CDK4. So in such scenarios, we have just the fulvestrant I have tried in 1 or 2 patients along with this hormonal therapy. So definitely quality of life is required in each and every pattern, and at the age which we are trying, and the PS definitely the responsible to adding these drugs.
Absolutely, I 100% agree with you. And just giving aromatase inhibitor, 1 tablet a day, either letrozole or exemestane, or just that will control the disease for maybe 2 years or 1 year. So that is not an inferior option or a bad option in the selected patient who has problems with the CDK4/6, right?
Yes, sir.
All agree? All panel agree?
Yes, sir.
Yes.
Great. So here is the toxicity breakup for you. And I think all of you are aware of this. Ribociclib, maximum or quite significant neutropenia, however, doesn't produce, this doesn't lead to usually febrile neutropenia. And with abemaciclib, we have quite a bit of diarrhea, but usually it is low grade. And as I think Ankur mentioned, we are quite used to treating and managing diarrhea. And cardiac toxicity, particularly QT prolongation, is a little bit of problem with ribociclib. And if you are contemplating ribociclib, and I think it's a black box warning also, you have to, at least for the initial few months, monitor the ECG and look at the QT interval carefully. Agreed?
Yes. Yes, sir.
Okay. So there has been some, publication data on the quality of life of the patients receiving these CDK4/6 inhibitors. And this again is a cross-trial comparison, probably not fair, but this is the slide which has been handed over to us. And it does seem that the quality of life parameters are maybe a shade better with ribociclib, with palbociclib as compared to abemaciclib. And this is primarily because of the diarrhea. So can you hear that sound? I'm not making that sound for sure. So anyway, the worsening of quality of life is probably because of the diarrhea. And as Ankur says, we are pretty, conversant and good at managing diarrhea, at least in Indian patients. So this is the various guidelines for you. And again, highlighting that you have, particularly in the ESMO guidelines, a strong recommendation for ribociclib, a grade 4 recommendation and a grade 5 recommendation. And for the other 2 agents, it is grade 2 recommendation. And this is primarily because of the, the overall survival, the lack of statistically significant overall survival benefit with abemaciclib. And this is the ESMO MCBS scale. All of us are aware of this. For a drug, either new or old, it is good to have a scale of 4 to 5 as compared to 1 to 3. So now one more question, and I think this is the last question. After this, we will finish. I don't want Devesh's program to be too late. But we can go until 12 o'clock if he wishes so. So if the patient has visceral crisis or if the patient has aggressive disease, what would be your choice of treatment? And I want each of the panelists to address this. Let me start with Dr. Ajay first. Ajay, visceral crisis, tell me how you define visceral crisis in your practice. And if a patient of hormone receptor positive metastatic breast cancer comes to you, HER2 negative, how would you approach that patient with visceral crisis? Ajay.
So if patient is having impending cord compression or severe organ dysfunction, then it is considered as visceral crisis. And in visceral crisis, I will prefer chemotherapy rather than the CDK4/6 or AI.
Okay. And Ankur, what would be your approach to a patient like this?
So visceral crisis, basically what I define is the patient who needs to get, admitted and needs some treatment immediately for any of the, complications. What I prefer is that I will prefer to give a CDK4/6 plus AI, because earlier the chemotherapy was used based on the concept that AI alone have not enough response rates. But we look at the response rates with chemotherapy in the tune of 40 to 50%. But with CDK4/6 AI combination, it's almost in the tune of 60%. So, sir, my preference, if patient is able to take orally, I will give CDK4 plus AI.
Very good. So I just love this controversy, different panelists opting for different treatments. I really like this. So Ankit?
Sir, recently we have shifted from chemotherapy to oral AIs and CDK4/6 inhibitors, even for visceral crisis patients. So because
yeah, please.
Same as Dr.
Carry on.
Ankur and Dr. Ankit as well.
Carry on.
Shifted away from chemotherapy in hormone positive patient.
Okay. And so patient who has a visceral crisis, you would still give CDK4/6 with hormone therapy, right? Jitendra, you agree to that?
Yes, sir.
So suppose a patient is having pleural effusion and she is on oxygen, admitted in the ward, massive pleural effusion and repeated tapping is done. Will you still prefer CDK4/6 or chemotherapy?
CDK4/6, still CDK4/6.
So I think Dr.
So
Ajay
only few subset where I will try to give chemo, probably carcinomatous meningitis in a hormone positive patient, where I feel that probably it's a diffuse visceral disease. So along with IT, chemo will stabilize the patient. Otherwise, pleural effusion, all these things we have tried, and patient usually respond well, because pleural effusion patients very difficult to give chemotherapy also.
So Devesh, you have to be the final arbitrator. You are the fifth person whose vote will decide this or that.
I think in visceral crisis, too, I think significant liver metastatic burden, as well as significant symptomatic for breathlessness. I think multiple lymphangitis, carcinomatosis, as well as the significant pulmonary nodules, where I have tried the weekly paclitaxel for 9 to 12 weeks, and further stabilization, I put on CDK4/6 and AI. So in 2 or 3 patients, I have tried in just way, where I find even after 3 cycles, I put on these strategies. So they have responded very well in these manners.
So my take on this is that we are in patients of metastatic hormone receptor positive disease, we know that chemotherapy is not very effective. We know that endocrine therapy is effective. We know that combination of CDK4/6 with endocrine therapy is effective more than endocrine therapy alone. So I actually don't see any reason why, even if the patient is sick and tolerability of these agents are much better than chemotherapy, I see no reason why it should not be given as first line. You give it as first line in the non-very sick patients, you give it as second line, you give it as third line, fourth line you reserve chemo. Why? Because these patients are not very sensitive to chemotherapy. And now we have a little bit of level 1 evidence. We had the right choice study, and you are all aware of the right choice study. And just show you this quickly. This is the PFS, and you can see in the first 2-3 months, the number of patients progressing are exactly the same as in both the arms. And in 6 months' time, if you can, get your patient to 6 months, then the curves start to diverge. And if you look at the, as Ankur mentioned, the response rates and the time to response, it is actually equal, if not better than when compared to chemotherapy. So again, I think this is where the art of medicine comes in, and both the options are quite valid, and each patient has to be individualized. But I really, salute the people who came up with this right choice trial. It was a very bold trial, and at least you have some backup now. If you choose to not use chemotherapy in these patients, you have some, at least one reasonable, well-conducted study to refer to that, which will support your decision making. But again, every patient treatment has to be individualized. Okay. So the overall responses, oral treatment versus chemo, exactly the same. And then it does make a case, this study, that you may not be very wrong if you choose CDK4/6 or ribo plus aromatase inhibitor. Anybody disagrees with this big time? So the patient has to be seen carefully, and individualized treatment has to be individualized, right?
Yes, sir.
Right.
Any comments from any of the 4 panelists?
Agreed, sir.
Yes, sir. Agree, sir.
Okay, and some people believe that Asians do worse with CDK4/6 inhibitors or better with CDK4/6 inhibitors. So a subgroup analysis has been done with Asian data on these patients, and just to cut a long story short, if anything, the Asian patients, this is the blue curve, they do a shade better than the Caucasian patients. So we can rest reassured that our genetic profile is not precluding the benefit of the CDK4/6 in our patients. So like you can rest reassured on that front. So I think guidelines, all of us are aware of this. This is the ABC recent guidelines, and 2 Indian authors were there on this guideline. So we're very happy about that. And some of the things which we have discussed are there in the guidelines, the Pan-Asian guidelines. So I think, Devesh, is it time to wind up?
I think, sir, within 1 or 2 minutes, we can wind up.
Okay, so now I think let me just quick answers from all the 4 panelists, starting with Ankur. Ankur, patient progresses on a CDK4/6, then what?
So ideally, sir, as I told earlier, I will do that if possible, PIK3 mutation testing, and I will add a PIK3 and go for a second-line endocrine therapy. For patient who doesn't have a PIK3 and patient who has taken palbociclib, there is some evidence that post-palbo, we can try either ribociclib or abemaciclib. Some patients benefit from that, so that is an option for those patients who doesn't have a PIK3 any mutation.
Right. Jitendra, your opinion?
Along with PIK3, NGS, maybe something we can get, and then probably we can take a call.
Yeah. And Ankit?
So we usually start with chemotherapy. Although there is data in continuation of the ribo, in continuation or changing over to ribo or abema after palbo progression, but we are currently switching over to chemotherapy if PIK3 is negative.
And Ajay?
Sir, PIK3CA mutation, if positive, then alpelisib. If not, then a patient has received palbociclib, either ribociclib or abemaciclib, or a patient has received letrozole in combination with CDK4/6 inhibitors, single agent fulvestrant.
Correct. So single agent fulvestrant or fulvestrant combined with the CDK4/6, and one CDK4/6. After that, there is emerging data now post-monarch, maintain, Pelriba, all these studies, that there might be a small benefit to continuing changing the CDK4/6, changing the endocrine partner, right? So these are data which are coming up, and in fact, every single patient who is on a CDK4/6 inhibitors will sooner or later will progress. So we have to be ready with a strategy to manage these patients also. So key takeaways of this panel discussion, with the permission of my 4 panelists. When you are choosing a CDK4/6 inhibitors, then ease of administration is important. You have to choose the drug as per the lifestyle of the patient and as per the wishes of the patient. And for most of the agents, in case there is unacceptable toxicity, you can go down one dose level without a huge loss of efficacy. So that has to be kept in mind, and we shouldn't feel too guilty of one dose reduction if need be. These are patients with stage 4 disease, and maintaining their quality of life is extremely, extremely important. With that, I'd like to conclude this panel discussion, and thanks to my 4 wonderful panelists, and thanks to Divesh for giving me this opportunity. Thank you.
Thank you, sir, for this talk and guiding us as a teacher. And definitely, we learned many more how to choose these drugs. Even today's sessions, we all know that even in visceral crisis, we can just try with this ET plus CDK4/6 inhibitors upfrontly, and so that we can titrate. And each treatment strategies can be individualized. Even Palbo, even with Ribo, even with Abemaciclib, definitely the individualized based on the quality of life, performance status, as well as financial status. So definitely we will choose, and now we are choosing all these drugs in a manner. We all treat these patients. Nowadays, the cost is not a constraint. So we are using upfrontly these drugs in these settings. So thank you, sir, for guiding us. And thanks all my panelists for today joining. Thank you, sir. And thank you, Novartis, for sponsoring this session. Thank you. And
Thank you.
Yeah. So for next session, I invite Dr. Vikas Goswami, who is the Director Medical Oncology at the Max Healthcare Noida. This is the AstraZeneca sponsored session, and the topic is the paradigm shift in the management of endometrial cancer. So over to you, sir, Dr. Vikas.
Thank you, Dr. Goel. Thank you for number one, giving me the opportunity, and special thank you for accommodating me before others. I'm sorry I had another session. So again, at the outset, I would say thank you for changing the slide schedule for me. I'll be discussing about primarily about how the paradigm shift means what is the role of IO in upfront setting in advanced endometrial cancers. So with that, okay, the slide should be changed at your end.
Yes, yes.
Fine. Okay, so can I have the next slide? So this slide basically shows the incidence of endometrial cancers in India, and the point of this slide is that endometrial cancer is one of the top 10 cancers affecting Indian population. To be precise, it's at the sixth position. Next slide. So again, a heavy slide primarily showing the heavy burden of endometrial cancers in India. Next slide. Next slide. So a bit about classification, how the classification of endometrial cancers has evolved from a basic TNM staging to now incorporating molecular classifications as well for the endometrioid variant of endometrial cancers. Next slide. Again, we know that both germline and somatic mutations may increase the risk of developing endometrial cancers. And if we talk about the specific mutations, which I'll be talking later, BRCA is one of them. which affects especially high-grade endometrial cancers. Next slide. So this slide basically now tells about how we incorporate molecular parameters into the classification and management of endometrioid variant of the endometrial cancer, especially in deciding the adjuvant treatment. So we all know about it, and this is not the topic for today, but just a brief. Now we kind of incorporate four types of subvariants where the decision about adjuvant treatment is based upon number one, pole mutation, number two, MSI, number three, P53, and a combination of these two. So by this, we have four classifications and we decide where to skip, despite being a high stage endometrioid cancers, where all can we skip giving adjuvant treatment. Next slide. So this slide again tells the same, that FIGO incorporates not just the TNM, but the molecular staging, early non-aggressive cancers, grade 1, 2, and grade 3, 4. This is how it was staged earlier. And now we have the incorporation of the four molecular variants. Next slide. Can I have the next slide? Okay. So, as per the updated ESMO guidelines, like I mentioned, they are classified into low, intermediate, and high based upon whether we have pole mutation, whether we have deficient or proficient MMRs or P53 mutations. Next slide. Next slide. So, for early cancers, surgery has been the mainstay, and how do we decide about the adjuvant treatment is guided by the mutations which I showed. Next slide. While early stage endometrial cancers are highly curable after hysterectomy, for most women, advanced metastatic and recurrent disease continues to pose a challenge, and thereby the need for the IO, which I'll be talking about in the subsequent slides. Next slide. Next slide. So establishing Paclitaxel as first-line standard of care in advanced endometrial cancers. So this basically is the famous GOG 209 study, which established a two-drug schedule, that is paclitaxel carboplatin, as the first-line standard of care for advanced stage 3, stage 4 endometrial cancers, and the comparator arm was a three-drug docetaxel, cisplatin, paclitaxel. We all have used these three drugs and then moved on to the double drug schedule after this GOG 209 study. Next slide. So basically, after the study, paclitaxel carboplatin became the backbone, and a double drug schedule was as effective than the three drug schedule with lesser side effects. Next slide. So next slide. So before moving on to the IO part, we also know that endometrial cancers, even if stage 4, can be managed with hormone therapy, provided they are low grade and they are hormone receptor positive. This is the other aspect we all know. Next slide. Next slide. So POTEC 3 study basically evaluated that rather than giving just adjuvant radiotherapy alone, what are the cases where we give chemoradiotherapy, and the schedule for POTEC 3 was for all those high risk cases which have been operated, CTRT kind of a schedule whereby 46 gray with 2 cycles of cisplatin 50 milligram per meter square, followed by 4 cycles of paclitaxel carboplatin were superior to RT alone. This is the crux of POTEC 3 trial. Next slide. So addition of adjuvant chemotherapy to radiotherapy should be recommended for women with stage 3 cancers to improve survival outcomes. Next slide. Again, various graphs to drive home the point that POTEC 3 is the way to go for stage 3 endometrial cancers. Next slide. Now comes the main paradigm shift, which is the combination of IO in endometrial cancers. So historically, the next few slides will first delve upon how IO was introduced as a concept in endometrial cancers, then how it replaced the second line, and eventually how it's now part of the first line study. So Keynote 158, this was a phase 2 open label study. It basically evaluated the role of Pembro 200 versus Pembro 400 in as a monotherapy in advanced cancers, including endometrial cancers. Next slide. So the main take home was that yes, there is durable anti-tumor activity in previously treated advanced MSI high or MMR deficient endometrial cancers. Next slide. Then is this famous Keynote 146 study, which investigated the role of Pembro plus lenvatinib in solid tumors, including endometrial cancers. This again is a phase 2 single group study which evaluated 200 mg pembrolizumab plus lenvatinib. Pembro was given up to 35 cycles, and the primary endpoint was response rates for this. Next slide. Here again, it demonstrated durable anti-tumor responses with the combination in patients with previously treated advanced endometrial cancers. Very, very importantly, irrespective of the MMR status, the benefit was seen in both non-MSI high and MSI high in PFS and OS. So thereby establishing the efficacy of this combination in endometrial cancers in second line. Next slide. Keynote 775 investigated second line platinum based chemotherapy versus Pembro plus lenvatinib in a phase 3 trial. This was again a 1:1 randomization whereby paclitaxel or doxorubicin based combination were evaluated against Pembro plus lenvatinib. Next slide. And it demonstrated superior efficacy of the IO combination in second line versus chemotherapy in people with advanced endometrial cancers. So we can see the Kaplan-Meier curves. On the left side are the PFS. On the left side are the PFS in proficient MMR. On the right side are the OS in proficient MMR group. So both kind of favor the combination over the chemotherapy arm. Next slide. So establishing the chemotherapy plus IO as first line standard of care in advanced metastatic or recurrent endometrial cancers. Next slide. This is a DuoE study whereby durvalumab is evaluated in combination with chemotherapy in a phase 3 manner and plus minus the PARP inhibitors. Next slide. Next slide. So this is a trial schema of the DuoE study whereby newly diagnosed FIGO stage 3, 4 or recurrent endometrial cancers with known MMR status, naive to first-line systemic therapy, naive to PARP inhibitors, who may have undergone adjuvant chemotherapy but more than 1 year away, and all histologies except sarcoma were accepted. This was a 3-arm study whereby chemotherapy alone, chemotherapy plus durvalumab, or chemotherapy plus durvalumab plus PARP inhibitors were evaluated. The primary endpoint was PFS and key secondary endpoints were OS and safety. Next slide. If we see this on the left side, we can see the patient characteristics were balanced, but what have they evaluated? Number one, Asian, non-Asian population and disease status, FIGO3, FIGO4, performance status. On the right side, more important parameters like MMR status, proficient, deficient, PDL1, more than 1, less than 1, HRR status, because they have used PARP. The number of patients are not much, but still they have tried to evaluate the role of PARP irrespective of HRR, and histologies. All histologies, like I mentioned, apart from sarcomas, have been included. Previous chemotherapies, previous radiotherapies, and previous surgeries. Next slide. Next, 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 next. Again, patient dispositions, how the treatment were planned, what kind of arms they had taken. Next slide. So in the intention to treat population, we have the PFS curve and the OS curve for the entire cohort of population. And if we can see on the left side, at the hazard ratio for the PFS is 0.71 for chemo plus durva arm in favor of durva, and chemo plus durva plus olaparib arm is 0.55. And on the right side is hazard ratio for the overall survival, which is again favoring chemo plus durva as 0.77 and chemo plus durva plus olaparib as 0.59. And all these numbers, more or less, barring the hazard ratio for overall survival, are significant. Next slide. And if we further analyze based upon the MMR status, so obviously if the MMR is in our favor, which is deficient, we find the hazard ratio jacks up to 0.42. But the important thing is, in this subgroup, the olaparib doesn't do much of addition. So if the deficiency of MMR is there, durva plus chemo and durva plus chemo plus ola both have a similar hazard ratio of 0.42 and 0.41. Similarly, if it is proficient, olaparib makes the delta in the form of, if you can see MMR proficient, the hazard ratio is 0.77. And if you add olaparib, irrespective of HRD status, it is 0.57. Next slide. Similarly, we have benefits in terms of response rates, and you can see the median duration of response for chemo is 7 months versus 10 months and 18 months for chemo, followed by chemo plus durva, followed by chemo plus durva plus olaparib, respectively. Next slide. So MMR subgroup for overall survival, previous data was for PFS. Again, they are kind of similar numbers. For OS, the hazard ratio is 0.34 and 0.28 if it is MMR deficient. That means olaparib is not doing much trick over here, but the delta is higher if it is proficient MMR. So in patients who have proficient MMR, apart from durvalumab, olaparib does increase the overall survival numbers. Next slide. Subgroup analysis as per PDL1 status. Again, so PDL1 more than 1, PDL1 positive or PDL1 negative, both the subgroups favored. And if you see the hazard ratio for PDL1 positive, by positive they mean just a score more than or equal to 1. The hazard ratios are 0.63 and 0.42 with OLA and without OLA. And if you have a PDL1 negative status, though the numbers are in favor of the combination arm, but the hazard ratios hover around 0.89 and 0.80. Next slide. This is the forest plot basically showing that proficient MMR, all subgroups benefit very, very importantly, irrespective of BRCA or HRD status and histology. Next slide. And if for proficient MMR, again, the delta is more for HRD status positive or unknown. Next slide. And because of olaparib. Safety summary, we all know that olaparib comes. We have used durvalumab, we have used chemo, we have used chemo plus durvalumab. Here, what is need to be understood is that durvalumab plus olaparib. So olaparib we have used in other indications. We know the standard expected side effects, especially bone marrow suppression and fatigue and asthenia. They are there and they are there in manageable form, not unmanageable form. Next slide. Again, grade 3, grade 4 side effects are more in the combination arm, but not in an unmanageable fashion. Next slide. So as per this, this is the NCCN guidelines, which say that the IO is approved. As per NCCN, though, pembrolizumab is approved across irrespective of the MMR status. Durvalumab is approved 3-4. However, as per NCCN, for now it is approved for MMR deficient tumors only. Next slide. Similarly, for advanced endometrial cancers, pembro plus chemo is approved for as category 1, and durvalumab is also there. But as per NCCN, for now, it is deficient MMR only, though the DUO-E trial, we have seen that irrespective of MMR, the benefit is there if we add olaparib. Next slide. So next couple of slides kind of repeat the message which has been said, but in other guidelines, for example, the ESTRO, ESGO and ESP guidelines, they are similarly repeating the message which I already conveyed in the previous slides. Next slide. Next. Next slide. Next slide. Next slide. Next slide. Yeah, next slide. Next slide. Next slide. So to conclude, endometrial cancers, we all know what is the role of the mutations in endometrioid form of cancers. Today we discussed about the role of IO in frontline. There is approval for pembro, there is approval for durva, there is approval for dostarlimumab. And what is important is that as per DUO-E trial, we can add durvalumab in frontline setting in all high-grade endometrial cancers. We can, irrespective of the MMR status, irrespective of other PD-L1 status, and if we add olaparib, the PFS and OS numbers are favored further. And olaparib does its benefit irrespective of HRD status and BRCA status. Possibly the theory is, though it doesn't work like this in breast and ovary, here the theory is that it turns a cold endometrial cancer into a hot tumor, which is further active, which is further then killed by durvalumab. So, but it's an evolving science how the combination is working irrespective of the HRD status and the BRCA status. And we also know that olaparib comes with its side effects, and we may skip olaparib in those patients who have MSI high or deficient MMR, because the delta in that subgroup of olaparib over and above the IO is not much. With that, I conclude. Thank you.
Vikas, for this wonderful talk. So, do you still agree that the durva can be used even patient is pMMR?
So, as per the trial, yes, we have some evidence.
So, but NCCN is approval only for dMMR only.
So, honestly, in my practice, unless it is mentioned in NCCN or I think DCGI, I am not sure what is their approval for DCGI. I resist doing that, not because I don't believe in the data, but because sometimes patients do come up with such kind of slides and question that if the other drug was available, what was the need to go to this one?
So definitely, I think with the addition of these immunotherapies, so the survival is also improved. And you are saying that olaparib can be added along with this durvalumab in PMMR setting.
Actually, as per trial, it can be added in both. But my submission is that since olaparib has so much of side effects and the added benefit is only seen in PMMR, like you're saying, I would restrict myself to using in that subset only.
Okay, thank you. Is there any inputs from your side in day-to-day in clinical practice beyond the guidelines?
For now, it's a very good addition, and the kind of PFS OS which has been shown, especially with the triple combination of chemo, IO, and olaparib, I think it's the way to go, and I would certainly be changing my practice with the approvals of the concerned authorities once they are mentioned.
So thank you, Dr. Vikas, for this session, and
Thank you.
thanks Astra for sponsoring this session. So for next session, I invite Dr. Jitendra Kumar Pehlajani, who is a senior consultant medical oncologist at HCG Cancer Center, Jaipur, and the topic is response or survival or both in recurrent and or metastatic head and neck cancer. Sorry, Jitendra, I think this is the last session. I think dinner is also delayed. I think you are not in day-to-day discussion. I think you are not taking dinner. I think you are just alive on this lunch.
I had my dinner at 6:30.
Okay, I think you have dinner 6:30. I think
Yes.
or
But my phone is hungry. Battery is about to die. So it's on charging mode. So
Yeah.
thanks, Devesh boss, for the opportunity, Mark for the slides, and this is a sponsored session, as Devesh sir has already told. So probably we will sift through, and I am probably in between many people's dinner. So just sail through what head and neck is giving us new. As we all know that medical oncology is an evolving science, but we have to dig deeper in the data for the things. So coming to the Indian patients in head and neck cancer. So in the Indian world, most of the cancer are oral cavity cancer because of probably tobacco smoking, chewing, alcohol. HPV prevalence is less because of the sexual practices what we have. Late presentation is usually the dictum in all malignancy what we have. We usually go here and there, do doctor shopping, and we'll end up in Devesh's clinic for the treatment purposes. So aggressive biology, usually the patients are symptomatic. Patients are younger, since of the long-term disease, they are nutritionally compromised. Comorbidities are lesser probably, but probably most of the patients are PS2 or PS3 in our scenario, except especially if you are talking about stage oral cavity cancer. Next slide. So next slide. So this is how it was looking like, but rarely now probably we are seeing patients in the early stages, T1, T2 also we are seeing. So probably we will switch from this, but yeah, we do see these sort of patient at OPD once in a month or once in 2 months. Next slide. So coming to this is a TMH study by Dr. Patil. This is what they try to understand that how these patient expectation are regarding treatment. As we discussed that patient expectation has to be kept in the center of what they want to have. So prolonged life, obviously everybody wants to live is around in 40% of the patient, but symptom relief along in combination with prolongation of life is the goal. So probably they want the symptoms also, and probably many of them want to continue chewing tobacco also, which we cannot provide, but this is what they want. Next slide. So this is how NCCN guidelines say, as we are discussing today, unresectable head and neck cancer, which is bearing the nasopharyngeal cancer. So both the agents, IO agent as well as targeted therapy agent, along with chemotherapy are the category 1 option. Although in our practice we usually do CPS to find out the way, but in this discussion we will probably dig through deeper in the data that whether we are missing something or we can think something different. Next slide. So this is the PDL1 and tumor burden score, which basically suggests us that how to sail through between this. This is a Chinese study where they analyzes the tumor burden score on the basis of volume of the tumor, and they put a cutoff on the CT scan finding with more than 5.66 and less than 5.66, and they evaluated 250 patients of recurrent metastatic head and neck cancer. 126 patients out of that was almost half of them were high burden disease. And if you see that median PFS in those patients was 7.1 months in low tumor burden versus 3.9 months, and OS was 14.2 versus 9.2 months. When we have given treatment with cisplatin 5-FU versus cetuximab EPF regimen or PPF regimen, means platin 5-FU with pembrolizumab. Next slide. So these are the Kaplan-Meier curve. As we can see, the above curve of EPF in high tumor burden PDL1 positive, slightly better. Probably we have limited number of patients, only 250 patients in PDL1 positive high tumor burden. Again, the overall survival is slightly better, which is significant statistically, 9.9 versus 6.4 months. In a low burden disease, in a high burden disease with PDL1 negative patients, the PFS was again better. So concluding from this slide that tumor burden is significantly correlated with survival and obviously quality of life in patients with recurrent metastatic head and neck squamous cell cancer. PDL1 and TBS both should be taken into consideration, but we need a bigger data set to conclude and put it in the guidelines. Next slide. Coming to the response, next slide. So as we can see that this is the global evidence of what targeted EGFR therapy along with chemotherapy can do. So we can use both the agents cis-5-FU along with EGFR as well as IO, and we can use taxane platin also with EGFR. So we can see that overall response rate in some studies like Change2, Extreme, arm of TP Extreme were in the tune of 50% or more, which is lesser seen in IO along with agent. But the overall survival was 10 months, 14 months. So here we should have, that's why we are digging deeper into the data, that what is a better sequencing or better initiating agent in these settings. Next slide. So this is the real world evidence, and here we can have we do have the study of overall response rate in cetuximab plus chemotherapy, like Rangaraju et al., Bahel et al., Chandrakant et al., and few Chinese study which suggested overall response rate vary between 45 to 82%, and the overall survival in Asian population did vary somewhere between 9.2 to 15.01%. So as we all know that these data vary, practices vary, like means many people uses only CPS. Now with available of generic, probably targeted therapy users are more. So those all type of things can be there. But yes, definitely this drug work and this combination is useful. Next slide. So treatment means definitely if somebody has a ulcerative mouth or unable to open his mouth and patient had a response, so definitely the response will decrease the symptoms and the patient will have improvement in symptom burden. Next slide. So coming to the CPS score, which usually many guidelines say that somewhere it is written 10, somebody is it said 20. So we can see that that doesn't happen with EGFR targeted therapy, that low CPS, high CPS, that is not basically for EGFR targeted therapy. But we do know that immunotherapy response rate definitely are dependent on PDL1 score. That's why we use PDL1 to decide whether to give immuno or whether to give EGFR inhibitor. Next slide. So this is the data of extreme ORR versus, but this data is basically when you give pembrolizumab monotherapy. So if the CPS is high, the response rate is still moderate in pembrolizumab monotherapy arm, because the patient who are responding to immunotherapy, probably their survival longer. That's why probably it is giving a PFS and OS equivalence. But if you see the response rate, that is more in the extreme arm, whatever CPS you take, it's upward of 35% and more. Next slide. So coming to the cutoff, as I was saying, that 20, 10, somewhere 50 or 80. So does CPS score provide a reliable response? So probably, as you can see, that Pembro Platinum, when we compare with Extreme, more than 20, it is almost equivalent or slightly better. But otherwise, it is slightly inferior if you compare only the response rate. Next slide. So this is the keynote 48, in where they have given, although this is a subset analysis of keynote 48 in Asian population, and we can see that Pembro chemo, it was doing slightly inferior when we compare with the extreme arm, but overall survival was almost similar in this data. Although 12 months difference was there, but when you see OS, it was similar. Next slide. So maybe subsite is an important part. We know tongue behaves differently, oral cavity behaves differently, and the GBS behave differently. Next slide. So here we can see that this is a cross-trial compilation of various extreme phase 3 tumor as per subsite. That oral cavity probably was faring far better. If you see intersaline basically the cetuximab arm, and real world evidence also suggested the same, which was a retrospective analysis. And this was also replicated in other study like Change 2 and Ankur Behar et al. Study, that oral survival was slightly better if you compare with the oral cavity with other subset of the head and neck cancer. Next slide. So here we can see in this original article of cetuximab study published in NEJM, where oral cavity subset was primarily benefited more when compared with the other subset. Next slide. So this is again the Change 2 data, where we can see that oral cavity subset was faring better when we compare cetuximab versus chemotherapy. Next slide. So this is the Indian territory study published by Dr. Ankur Behel et al. From Gurgaon. So here we can see that oral cavity patients were more, and they responded better when given with cetuximab on the tune of 92%, and the disease control rate was 84%. Next slide. So this is what the Kaplan-Meier curve looks like. That chemo with cetuximab, the median OS was 12.3 months. When we given chemo alone, it was 5.80, and the difference was slightly lesser when we were given in larynx and oropharynx. Next slide. So this is the subset analysis when we compare with oral cavity, and here also we can see that oral cavity was favored when we compare with other subset. Next slide. Now coming to the oral cavity side cancer, because probably the hypothesis is that there are more immune suppressor cells, so that's why immune checkpoint inhibitors are probably working lesser in oral cavity subgroup. Next slide. So this is the study or subset analysis of oral cavity subtype when you analyze it in a Chinese study, where they have given that oral cavity patients are in the between, and probably HPV patients, which are more in the Western data, are more benefited with the immune checkpoint inhibitors. Next slide. And this is the chemo or cetuximab in recurrent diseases. So here they have compared with pembro along with chemotherapy, and here they have seen that pembrolizumab in the oral cavity, which was crossing the basically the what we can in the metastatic setting, it was crossing the midline, crossing the this is a cross-trial comparison of keynote 48. So probably the oral cavity immunotherapy works little lesser, but still we need more data, robust data to say it so. Next slide. Coming to the sequencing, whether sequencing IO followed by EGFR or EGFR followed by IO, whether does that impair the or improve the survival? Let us see the data, how data suggests us. Next slide. So this is how Arbutex or cetuximab used to work. That one, we all know that is a EGFR targeted antibody and blocks EGFR receptor, and that's why it causes apoptosis, cell death, angiogenesis. So probably next indirect effect, what we have been seeing, that it leads to increased PD-L1 expression. PD-L1 expression, as we all know, there is a dynamic marker. It can vary with chemotherapy. It can vary in metastatic disease, and it can vary also after immune therapy exposure, cold and hot tumor, which we can see. Next slide. So if you sequence the tumor by TPXT followed by means if TPXT was given at the first line, so probable survival is around 21.9 months. If you give extreme followed by checkpoint inhibitor or TPXT followed by checkpoint inhibitor, you are touching somewhere 21 months. This is the follow-up data of TPXT and XT. Next slide. So this is the retrospective study which was published by a Chinese researcher between 2017 to 2020. N number was 75. They have given cetuximab cisplatin 5-FU versus pembrolizumab cisplatin plus 5-FU. Although the N number is low, followed by the other agent along with taxane, and there they have seen that almost similar overall survival has been achieved, and response rate was better when you give cetuximab earlier. Next slide. So this is the real world data of Indian data of weekly paclitaxel versus along with Erbitux followed by nivolumab, and here they have given 54 patients which were platinum sensitive. The overall response rate to the cetuximab paclitaxel was 79%, and on progression patient received nivolumab or OMCT. Next slide. So in this study of Dr. M.V. Chandrakanta, the median overall survival followed by EGFR inhibitor followed by nivolumab was 20.4 months, and OMCT, as we all know, it does definitely respond very less. Next slide. So coming to the sequencing, so these are the various Indian study and Western study, that if you sequence EGFR inhibitor followed by checkpoint inhibitor, you can achieve somewhere 17 months versus 23 months in a relapsed refractory head and neck cancer. Next slide. So this is how the Kim et al. SMO 2020 article has suggested that pembro monotherapy is favoring only small tumor burden, indolent disease, late relapse, small disease. If the disease is recurring after RT, probably cetuximab with chemotherapy or pembrolizumab with chemotherapy. If patient required rapid symptoms, probably EGFR inhibitor. If tumor is recurring early, rapid growing tumor, bulky tumor with necrosis, probably EGFR inhibitor is the choice. Next slide. Here they have not taken into consideration the PD-L1 expression. Next slide. So coming to the conclusion that each patient with relapsed refractory head and neck cancer is unique. Treatment should be based on patient needs. Genetically and etiologically, Indian patients are different, as we all know. Factors like tumor site, tumor symptoms, burden of the disease, pace, biomarker status are important. like oral cavity cancer is an immune suppressor tumor, as per the data suggests. For response or survival, cetuximab plus chemotherapy provide consistent, powerful start in Indian patients in respect to response rate. Cetuximab plus chemotherapy followed by ICI can provide median overall survival of 24 months, and it also increases PD-L1 expression. With TP extreme subgroup analysis and real-world experience, cetuximab-based regimen in first line followed by immunotherapy in second line, OS can be reached from 17 months to 20 months. This is all from my side. Over to Dr. Devesh.
So thank you, Jiten, for this nice talk. And I think in clinical practice, what is your observation in day-to-day where we should prefer this drug over the IC immune checkpoint inhibitors versus this or this? And second is a generic cetuximab versus research cetuximab. So where you find these two questions?
So number one, I use CPS more than 20. If it is more than 20, I give IO. If it is less than 20, probably EGFR inhibitor I will give. This is 2-1. Second, I usually don't take disease burden in consideration, majority of the cases. Second thing, regarding the generic versus innovator, see, that data probably nobody can say that how it works, but it is a difficult molecule to make, as we all know that even after patent got off, it took 7 to 8 months to make it. So quality is a constraint, but I don't say that one is better over another. But
okay, fine. So thank you, Dr. Jiten, for my invitation and very well discussed about this topic of the recurrent head and neck cancer and the role of Erbitux. So we conclude our second day session now. So to discuss today the various aspects of the various newer trials in the breast cancer as well as the thyroid cancer and the lung cancer, the gynec cancer. So we all discussed about these aspects. And yesterday we discussed about the lung cancer as well as the GI cancer. So we all know in the 2 days journey, we know that what is required in day-to-day practice. So which is very important. And what next? So in futures, the fewer trials are positive even in GI cancer, the role of immunotherapies. When the gynec cancer, endometrial cancer. So role of immunotherapies day by day, the indications are increasing and improving, and the data based. Even in this breast cancer, the role of the CDK4 inhibitors is also increasing. And nowadays, I think 2 or 3 drugs are in the pipeline for the in the next 2 or 3 years. So thank you for all my teachers, my colleagues, as well as my friends for their participation as a moderator, as well as a speaker, as well as panelist. And thank you all pharma industries for supporting this scientific feast and their sponsoring their sessions. And thank you from the Horizon team, especially Geetika, for enhancement as well as the very well smooth coordination in throughout the journey, from participation of pharma companies to discussion with this panelists, moderators, and the throughout in the 2-day journeys is smooth conducting of sessions to all that Horizon team, Yashika, Geetika, as well as tech support, and especially last thanks to Dr. Tarun Mathur for encouraging me to initiate this event. Thank you all.
So thank you so much, Dr. Devesh sir, for the lovely comments, and thank you all the faculties to join in 2 days event. Thank you, Ashika, for the support, and thank you, tech support, for the technical part. Thank you.